for BTA Interventions. So this is my disclosure slide. So what are we dealing with? We are dealing with very complex disease below the ankle. As we deal with below the knee disease, we are talking about a complex morphology, long diffuse vessel, heavily calcified vessels, total occlusions are common. So this is a very severe disease situation below the ankle. And the question is this hype or help? I definitely think below the ankle intervention is a standard now. If we don't have outflow, the inflow does not be sufficient enough to heal a wound. So pedal intervention, I think, is absolutely important. Although that we have new endovascular tools available, we unfortunately do not have any RCTs. We have small registries, maybe. We do not know so much about risks. But when we look at the data, we can say that there are even some meta-analysis about that. This is a nice meta-analysis here from Dr. Ünlü and Dr. Schrewe from the Netherlands. They clearly stated below the knee ankle intervention is safe and effective. So the question is, what can we do better in terms of technical things to get a very good functional outcome in this patient? And I think it all starts with visibility issues. Even with modern angiography, it's sometimes very complex and difficult to analyze vessels in the pedal arch region. So what can we do to enhance here the visibility? Of course, we can do local injections, but the question is, and this is the talk about it, do we have new technology available here to enhance visibility below the ankle? Yes, there is definitely. I would like to introduce to DVA. You see on this is on the left side a 5 milliliter contrast injection via P3 selective injection. And on the right side, you see the new technology called the Kinepic, the DVA technology, which is a 4 milliliter contrast via sheath from P3. And you see the difference between DVA on the right side and ESA on the left side. So what is DVA? This is this company from Hungary. It's fully CE and FDA approved, which uses, this is the algorithm, a DVA algorithm, which calculates the variance between the consecutive images of the angiographic sequence. So what you just need is a DSA, and with an algorithm, just via an HDMI cable to the computer, back from the computer to the DSA monitor, you get a much better visualization, especially below the knee. Here you see the Kinepic medical imaging tool setup. It's just a computer and two HDMI cables and a small investment. And with this, you can definitely significantly improve the angiography quality below the ankle. And I think this is important for interventionists who want to do an intervention there. So there are even a lot of papers for this published. This is a very interesting one because they could show here that with this DVA technology, the quality over lifetime improved in comparison to standard DSA technology. So it's all about visibility. This is one of the technologies I would like to show you. A technology which probably you both from Spain already use quite a lot. I guess this is percutaneous intraluminal cracking using puncture needle. This is cheap. This is cheap. You just need a needle. You crack the calcification. So if you want to invest in new technology, and this is a nice paper here, you can just crack calcification in the pedal arteries with this needle technology, which is described nicely in this paper. Absolutely cheap. It only costs a few cents and not much money. So when we are talking about dedicated devices more in detail, I think one is important. I think we should stop POBA in the foot. We know about issues with standard balloon angioplasty in terms of unfolding injury, barotrauma, etc. And we now have scoring devices, specialty balloons available, and there are pedal data available. This is one of the devices which is approved for this scenario. This is the Serenator balloon from Cajun Vascular. It's fully approved in Europe and the United States. It comes with a 2.0 millimeter small balloon, and with this you can dive nicely into the pedal arch and revascularize the whole pedal arch with this specialty balloon and create good lumen. You see the Serenator, and the SL Pro is the device for pedal intervention. This is the mode of action. Here you see the angioplasty achieving lumen gain technology. You see these point force serration bags on this balloon, which dive deeply into intima and the media calcification. This is a study which we recently conducted together with US colleagues, a retrospective multi-center analysis for pedal intervention with this device, and we could see and found 97 freedom from major amputation at 5 months, no complication, and 42% of the patient improved to Rutherford 0 after intervention. This is just an example. I hope the video is running. So this is around the malleolus occlusion, as you can see here. This we treated with this device here. This is a 30120 millimeter balloon, which we use to open this area here into the lateral plantar artery. So we inflated this just to 4 to 6 atmospheres, waited 2 minutes, and then we had a very nice outcome here with this 30 millimeter device. As you could see here, no dissection, no significant recall. Another device which was recently analyzed for this is the ultrascore balloon, which is also available for the BTA intervention down to 2 millimeter scoring device. This study here was recently published. It's an ultrascore focused PTA balloon study below the ankle, below the knee study. And we analyzed patients with Rutherford 5 category. And you could see here we just had 16 minor amputation in a Rutherford 5 cohort, no major amputation in this patient cohort. One device which we frequently use here in our institution is the orbital atherectomy, especially for pedal intervention. A device which uses the orbital atherectomy principle here provided by the CSI technology. You see the stealth mode system. This is an orbital atherectomy system which you can use with different crown sizes at the tip of this catheter. It retains up to 120,000 rounds per minute, debulking the calcification, the intima calcification, media calcification. And Dr. Polina recently published a small cohort of patients. 12 patients showed a very nice technical success for pedal intervention, her highest limb salvage rate, and a high amputation-free survival rate of 50% at 6 months, and CDTL at 6 months, 91.7. So in sake of time, we have a lot of new tools available. Unfortunately, the RCTs are missing. This is, I think, what is needed now, that we set up direct comparison trials to find out which modality is best for pedal intervention. Thank you very much.
It's given me a great pleasure now to introduce Dr. Marta Lobato from Spain. She's going to talk